when I talk about IVF, this would be a conversation that happens after some treatment, and sometimes we do need to go into IVF immediately if there was a diagnosis of, for example, tubal factor, or sometimes some patients want to do that for genetic testing of the embryos. And there are multiple reasons why we dive into IVF immediately, and sometimes we do it after IUIs. But let's say we are at that point where we need IVF. What is the usual talk that I give patients at that point? And it usually comes as the general idea would be a lot of patients would start on birth control pills, and that's what we call a PrEP. And usually it quiets down everything so that we can start with the injections. Then after that, the patient gets her period after 2 weeks, and we start with injections. Usually the injections are 2 to 3 injections every night for about 2 weeks. And I tell patients in the mornings, in those 2 weeks, every 2 to 3 days, we're doing an ultrasound and blood work in the morning. Us as providers, what we do is we look at the ultrasound and the blood work around noon, and we say, okay, let's increase the dose, let's decrease the dose. What we're trying to do, and if we look back at the physiology of the menstrual cycle, usually in a regular menstrual cycle, what we have is a cohort of follicles, and you might know that cohort of follicles from your antral follicle count, which is the ultrasound that we do during the workup. But that cohort of follicles usually grows together without any medication. And then one dominant follicle grows, and it doesn't let the other follicle grow. The smaller follicles die, and that big follicle dominates, and that's the one that ovulates. What we're trying to do with IVF is to stimulate all that cohort and all those small follicles. We don't let them die. We stimulate them all with those 2 to 3 injections at night. And what we're trying to do is get to a point where we have a lot of follicles that are dominant. So right now in the story, we are taking 2 to 3 injections every night, every 2 to 3 days in the mornings. And usually our offices open up at 6:30 a.m. Patients come in, they do their ultrasound and blood work, and they go off to work. And then we look at those ultrasounds and we try to see how that cohort is growing. We want as many of those follicles to grow as possible. At the end of those 2 weeks, it's unpredictable when those 2 weeks would end, but usually it's around 2 weeks. We find that there's enough follicles that are big enough for us to retrieve. Why do we need big follicles? Because big follicles will give us mature eggs. The smaller follicles that did not stimulate wouldn't have eggs or wouldn't have mature eggs. And not all the follicles will stimulate, and not all stimulated follicles will have eggs. But we try our best to stimulate as much as possible and not to overstimulate. So there's a fine balance, and that's where our job comes in as providers. We're trying to stimulate, not overstimulate, but we stimulate enough to get enough follicles to get enough eggs. So what IVF does is that when we get to the egg retrieval, we tell the patient, okay, take a trigger shot. And what the trigger shot does, it mimics ovulation, just like in a regular menstrual cycle. And usually that's a different injection than the injections that the patient was taking before. And that injection helps the patient basically mature those eggs as if they're going to ovulate. But instead of ovulation, we tell the patient to go to our surgery center where we do the egg retrieval. With, for example, our Massachusetts patients, they go to Waltham in Syracuse, they go to the Syracuse center. In Albany, they go to the Albany Center. But in those big centers is where we have the egg retrievals. And the egg retrieval itself is usually around half an hour. Patient would not eat anything after midnight. They would come in, and then they would go and undergo the egg retrieval. Usually it's light sedation, and what patients describe it as is as the greatest nap. The usual or the majority of patients say that around that time, they are usually bloated, fatigued, and that's the most common complaint, but not usually complaints beyond that. We do the egg retrieval. It takes around 5 to 10 minutes itself, but usually half an hour is blocked for it. And then patient wakes up. We tell them how many eggs they got. The next day, they are told how many fertilized, for example, if they are doing IVF, or for example, how many were mature if patient is doing egg freezing. And then a week later, patient would find out how many embryos we have. And basically, that's it. A lot of patients ask about recovery after IVF, and we tell them it takes around 1 to 2 weeks up until they get their period. And it's usually the estrogen withdrawal around their period is what's a patient describe as PMS symptoms. And then after that, they go back to around 100% functionality after their period. But during those 2 weeks before their period, they take it easy, and it takes a bit of time for them to have less cramping over that time. But basically, that's it. That's the summary of how an IVF cycle goes. So throughout that cycle, instead of relying on one follicle or one egg, we are retrieving a lot of eggs and summarizing a lot of cycles into one cycle. And that's how IVF increases the chance of pregnancy, because once we get these eggs, there's kind of a selection process, which ones will fertilize, which ones will become embryos, and which ones we are going to transfer. And that's how IVF can increase the chances from, for example, 15% with an intrauterine insemination to around 50%, for example, with IVF. Of course, this is the general idea of IVF. At Boston IVF, we individualize care. We try our best to each patient individualize their care with different injections, different protocols, different triggers, and even different insemination techniques after we get the eggs. And, a lot of patients have questions about IVF that they heard from a friend or they found online. And I always tell patients, you cannot apply those rules to yourself. And the thing that I always repeat as well about IVF is that the biggest teacher in IVF is a previous IVF cycle. We learn a lot about the patient from an IVF cycle. However, it does increase their chances tremendously if they have not found success before. And basically, that's the talk that I give with each patient once we are at that point where we're progressing towards IVF. And with that, I'll conclude my small talk about IVF, and I will start looking at the questions that are given to me to answer them. I see one question. What are the risks, side effects you have seen or seen often with the trigger shot HCG? So the HCG is a trigger shot that we use often. We use it with IUIs. We also use it with IVF. The major thing to know about the HCG trigger is that it's very important to give if we are doing a fresh transfer. So if we are retrieving the eggs and then transferring an embryo around 3 to 5 days later, that HCG provides support for that embryo to implant. However, we have to keep in mind that HCG can exacerbate ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome is a situation where a patient is given stimulation medications and overstimulates. And we see that sometimes with patients, for example, with PCOS, and sometimes with regular patients. And what we try to do is avoid ovarian hyperstimulation syndrome, which is when a patient might get sick. She might have a lot of fluid in her abdomen, her urine decreases, and there are other symptoms with ovarian hyperstimulation syndrome. HCG triggers might exacerbate that. So we try to avoid HCG triggers if the patient is at risk for OHSS. That means if the patient has a lot of follicles, if the patient's estrogen is very high, or patient has PCOS, we try to avoid the HCG trigger and give a Lupron trigger. But that makes us lean towards freezing everything instead of doing a fresh transfer because we're not giving an HCG trigger. That's the major side effect of HCG, is to put you at risk for ovarian hyperstimulation syndrome. So, is it safe to see the trigger shot, to use the trigger shot if I have a paratubal cyst? I see ovarian cyst is not safe to use this medication. So, paratubal cyst should not be a contraindication for a trigger shot. As for the ovarian cyst, it's hard to say because a lot of it depends on who has defined that cyst. If someone is being stimulated, we usually look at the ovaries and look at what's a cyst and what's a follicle. Usually a simple cyst, it's okay to use the trigger. What we usually try to do is to not confuse the simple cyst with a follicle, because a follicle is a big cyst, basically. But a paratubal cyst should not be a contraindication to an HCG trigger. What steps can you take to improve egg quality before an egg retrieval? How long before should you do these things? That's a good question. So the most important thing about egg quality, now, of course, we know that age is an important factor, but that's not a controllable risk factor. But what's controlled is a healthy diet. And a lot of patients ask me, what healthy diet should I do? It's just a regular balanced diet. It's not eating a lot of sugar, not eating a lot of fat, just a balanced, healthy diet. And you might look up online things like a magical diet or a fertility diet. The research shows that just a healthy diet, a balanced diet would be good for egg quality. Exercising is very important to stay healthy. If you have a weight problem, try as much as you can to lose weight. That's important for the egg quality. If you smoke, not smoking improves the egg quality. If there's anything that you do or take that is unhealthy, try to have healthier habits. That's the most important thing when it comes to egg quality. Now, there's a lot of things online, for example, about human growth hormone. So far, human growth hormone has not been proven to be beneficial for egg quality. And maybe research in the future might disprove that, but so far, all the research is showing that human growth hormone does not improve egg quality. Another thing, for example, is supplements. A lot of patients ask about supplements. You know, there are different ones out there. There's not one major supplement that improves egg quality. I usually tell patients, you know, prenatal vitamins are the most important thing. And, you know, if you want to choose one supplement, maybe CoQ10. CoQ10 is a good supplement to take. Usually I advise them to take around 300 milligrams, and you can find it over the counter. How long before should you do these things? Right now. It's not important. It's, you know, if you can right now to start all these healthy habits, all these prenatal vitamins, CoQ10, exercising, losing weight. Even if you're not cycling soon, starting it right now, you'll be better prepared for your cycle in the future. And basically, that's it. Can you speak to the level of exercise movement allowed during a medicated cycle? That's an important question. So, during a stimulation cycle, we tell patients to take it easy, not do very vigorous exercises. And I'll explain why, and that's how patients know what to do and what not to do. When we're giving all these injections, the ovaries become bigger and bigger. And once they become bigger and bigger, they are at risk for torsion. So if a patient, for example, does CrossFit or HIIT exercise or jumps up and down, she is at risk for ovarian torsion. And that's in a medical emergency where patients have to go into the ED and we have to operate in order to detorse the ovary. After the procedure after the egg retrieval, it's the same thing. The ovaries are still big. So I tell patients, wait until your period, then your ovaries might go back, would have gone back to their original size, and then you could start exercising bit by bit. During a transfer cycle, it depends on the transfer cycle, but also I tell them to take it easy. Usually you can do your regular exercise even after the transfer for maybe a couple of weeks, not be too rigorous. But then bit by bit, as you progress through pregnancy, you have to take it easy more and more. And there's a lot of prenatal exercises online that you could adhere to. Find what you like and take it from there. I see here a question. My husband and I just had a miscarriage with a 4AA embryo. We have two remaining embryos that are 6BA and 4BA. Are these considered good quality, and do we have good chance of success? So, to answer that question, let's go back to morphology. So, unfortunately, morphology is not a major predictor of success. Morphology is used because when we look at embryos, there are certain things that we look at that can give us an idea whether this is a healthy embryo versus an unhealthy embryo. And that's how we, for example, choose which embryos should be frozen versus which embryos will not make it. As for example, the difference between a 4AA embryo or a 5AA or a 6BA, or which one will get pregnant and which won't, they usually don't have a big difference when it comes to pregnancy rates. It's a way for the embryologist to choose which one to transfer before the other one, but it's not predictive of which one will get pregnant. What's most predictable, what is most predictive about these embryos would be age. Age is the biggest predictive factor about whether these embryos will implant or not. And even when we have a genetically tested normal embryo, a genetically normal embryo that's genetically tested, that's a 55 to 60% chance of pregnancy. So having a miscarriage after a 4AA embryo, and I'm very sorry you had to go through that, doesn't mean that you'll have to choose based on morphology of the others. And and then it also depends on your age and what your prognostic factors are. Just looking through the questions. I have suffered a back injury last year in an auto accident. Will this affect my chances of IVF being affected? I am age 47, healthy weight, active non-smoker. Let's talk about back injuries. With back injuries, yeah, I'm so sorry you went through that. With back injuries, what it, most likely, if it's only to a musculoskeletal injury, it won't affect your fertility chances. But it is important to see a high-risk maternal fetal medicine doctor to assess if you can be healthy throughout the pregnancy. That means the pregnancy itself might be burdensome on your body, on your back, on your health. So are you at a point where you can be pregnant, progress through pregnancy, and deliver a baby? That's the most important question, rather than whether it affected your fertility or not, especially if the injury is musculoskeletal. It shouldn't affect your fertility, but being able to be pregnant, deliver a baby, um, a maternal fetal medicine specialist should sit down with you, go through your history, go through the back injury, go through the images, and say, hey, this is what you should expect throughout pregnancy. That question continues. I'm age 47, healthy weight, active non-smoker. Unfortunately, in this case, it wouldn't be the back injury that affects the fertility, but it's age. At the age of 47, the chances of fertility are much less. That's the biggest obstacle in that case. But schedule a consult. We go through all of this. We go through the back injury. We go through the age. We go through what resources we have in order for you to get pregnant. I see here. What do you think about sterility support for men? So, you know, we do see men throughout our practice with fertility issues. I always give this talk. We look at when a patient comes up to us with their partner. We do the semen analysis. We look at the semen parameters. We look at the motility. We look at the morphology. We look at the concentration. We make sure that everything's okay. A lot of patients, for example, ask, are there any supplements? Are there any other things that we should take? And I always tell them the exact same thing. Stay healthy. If you have unhealthy habits, cut them out. If you smoke, don't smoke. If you do drugs, don't do drugs. Try to exercise, try to lose weight, try to stay healthy diet. That's the most important thing. And then, some patients want to go further, or some patients have problems with their semen parameters. And what we do at, for example, at Boston IVF, what we do is we refer to urologists, male fertility doctors. For example, here in Massachusetts, we work with Dr. Lazaru, who's amazing, and we would refer our male patients to them, to Dr. Lazaru, and he would see them in the clinic, assess them, and give them advice about supplements and which supplements to take, and if there are any supplements that would help in their specific case. And usually that's very helpful. And Dr. Lazaru usually comments on what would help them in their fertility journey when they come back and they see us as providers by telehealth. I see here, is assisted hatching a must for frozen embryo transfer? And what are the benefits, disadvantages? There's always debate about assisted hatching. Sometimes we use assisted hatching, for example, when an embryo is growing and an embryo is still inside the shell. And sometimes what we need to do, if, for example, the patient wants to genetically test the embryos, we use assisted hatching in order for the embryo to hatch out, and we biopsy that embryo. And what it does is we help the embryo hatch, and once a few cells come out of its shell, we take those cells and we send them out for testing, and we freeze the embryo. That's the most important role of assisted hatching. Now, there are some studies about whether assisted hatching would help with implantation or not. Jury's still out. Some providers do that, some providers don't. It's still not something that is by guideline, but unfortunately, a lot in our field is still not by guideline. And sometimes we do it if we need to give that extra boost, or if the provider thinks that that's might be best in that specific situation, but it's not something that can be applied to all patients. And do you recommend that every patient should utilize assisted hatching? When would you recommend it not to be necessary? Again, ask your provider, because sometimes this assisted hatching is necessary when it comes to certain procedures, such as, just like I said, the biopsy part. But sometimes it's used if a patient is a candidate, and talk it through with your provider. We're always open to conversation. We're always open to the patient saying, why are we using this? Is this necessary? And the provider is always open to saying, hey, this is why I think we should use it. Or sometimes the provider would say, it's not something that I'm attached to. If you want to remove it, we could remove it. This was my way of thinking. We're always open to these conversations because unfortunately, our field has a lot of things that we add on or we remove, trying to individualize and trying to see what would succeed with this patient. I see here, what would you recommend to a patient that has had several failed IUIs and failed FET with a suspicion of endometriosis, but no endometriosis testing has been done by REI, another egg retrieval versus another FET versus pursuing endo testing? I'm not totally sure. So it depends on the patient. That conversation is very specific, but let's talk about endometriosis just as a general topic. So, unfortunately, endometriosis can cause infertility. It can cause infertility by, for example, if there's a lot of endometriomas, which are blood-filled cysts on the ovaries, and they prevent us from retrieving those eggs. But also, endometriosis can cause scarring inside the abdomen, preventing those tubes from transporting the egg into the uterus. And even with IVF, if we're just putting the embryo inside the uterus, endometriosis can have an effect of preventing implantation. There's a lot of things that we do with endometriosis. We try our best to avoid surgery because surgery might if there are endometriomas, if there are cysts, and if the ovaries need to be operated on, we try to avoid that because if the ovaries are operated on, that might decrease the ovarian reserve. So we try our best to avoid surgery in those cases. Sometimes surgery is unavoidable. We have to do it, but we try to avoid surgery before an egg retrieval. After an egg retrieval, it becomes a conversation with the physician. Sometimes we attempt an embryo transfer with certain protocols. Some protocols are specific to endometriosis. If that doesn't work, we might go towards surgery, but sometimes the doctor tries to avoid surgery as much as possible, and depending on the patient. And that's a conversation, that's an ongoing conversation with the patient. There are protocols that we use with embryo transfers that are specific to endometriosis. And sometimes we don't do the transfer until we do the surgery. So there's a lot of individualized testing and individualized testing protocols and certain management protocols that are specific to these patients. So keep the conversation going, ask these questions to your provider, and we're always more than happy to address these questions. And we always have resources for surgery. We have surgeons in our practice that operate on endometriosis. And if you have a specific surgeon, we're always happy to talk to them in order to provide with the best result. Um, I don't see a lot of questions that are being posted, or at least I answered most of the questions that were posted. In my, I'll just say a few things about IVF, and then we'll probably wrap up. I started this talk, or at least this conversation, with IVF 101. And I gave a big picture about how IVF goes and what it entails, the injections, the trigger shot, the retrieval itself. There's always things that come up to patients during the IVF cycle that they didn't expect. And the injections themselves are very challenging to do them. You're doing them by yourself. The first time you're watching videos, you're not sure whether you did them right or not. And that's okay. You're not alone. Everyone goes through that. And we're always here to help. With Boston IVF, you have the Artemis app, and talking to your nurse, talking to the people you are connected with on the Artemis app is a great resource, and we can always answer questions there. As a provider, I always get questions through the Artemis app, through my nurse, who usually, for example, filters those questions or tries to answer the questions. But if there are questions that she cannot answer, she emails them to me, and I answer them usually within the day. So we're always happy to answer those questions. Things that are, not predicted, or at least feedback from the patients during their IVF cycle. One major feedback that I get, which I usually try to explain, is that, hey, we didn't see you as our provider. You didn't do our retrieval. We didn't see you. Unfortunately, our practice is set up where there are on-call doctors, and usually we are a pool of doctors. Everyone is is the expert in their field and extremely competent to do egg retrievals. But because the egg retrieval itself is not predictable when it would happen, it's usually whoever's on call that day doing the egg retrievals. For example, I'm doing egg retrievals this Sunday. I might be doing egg retrievals for some of my patients, but also some of other patients or other providers' patients who happen to have their retrieval on that day because their cycle took those numbers of days, and it happened that that's the day that they are ready. However, their provider is usually behind the scenes, managing everything, deciding when to trigger, when to do the egg retrieval, when to do the transfer, everything. So they're always behind the scenes. And if something happens during that day or something that is abnormal, usually they are notified immediately. So we're always behind the scenes working. But that's the major feedback that I get from patients doing their IVF cycles, that they didn't see their provider. And I do apologize about that, but we are behind the scenes. We are working 24/7 in order to provide you with success. With that, I wrap things up. Thank you everyone for joining, and thank you for submitting your questions. And hopefully you enjoyed the series of Fertility Awareness Week. Thank you.